Good afternoon, good evening all. Can you hear me? Perfect. Just apologies for being a little bit late. As you all know, I'm Ola. We've got a lecture today by Dr. Kilali. I will get it wrong this time, I promise. On acute management of sickle cell painful crisis and pediatric. And then I just want to say she is a pediatrician with special interest in hematology, oncology, and allergy. And she did specialist training in Royal London Hospital, Great Ormond Street Hospital, and other hospitals across London, with over 15 years of pediatric experience. So I believe you all learn a lot from her today. I will give it a few more minutes before a minute before I start, and then I will pass over to you, Doctor, and then you can just go with your lecture.
Thank you.
No, thank you. And thank you for giving the presentation to me yesterday.
Yeah.
Sorry, I'm on annual leave, so.
It's all right. It's fine. Thank you for bearing with me.
No worries.
Yeah, just all over the place. I think before we start, we'll probably talk about some house rules. So if there are questions and things, to put them in the.
Yep, you put them in the chat, and then I will send them. I'll say them to you at the end of the lecture.
Okay.
Also, if anyone wants, usually they sometimes put their hands up or just unmic themselves, and I just ask questions that way. There's also a Slido at the end, so if anyone has questions post lecture, they'll put it in the Slido, and I'll just send them over to you.
Fantastic.
Perfect.
And then the other question I was asking Carol was, do you have a structured survey or feedback thing that you send out afterwards? I didn't think of that till just now.
Not after each lecture. I plan to send one at the end of the whole.
At the end of the whole thing. Oh,
yeah.
okay. All right,
Yeah.
that's fine. That's
cool.
fine.
I think you're okay to start if you want to go ahead.
Fantastic. Okay, thank you very much. So I'm Dr. Kilali. Omino Boat, everybody just calls me Kilali. And like she said, I do pediatric hematology oncology, and in England the training tends to go together. I work at the Mid and South Essex NHS Trust, which is in Essex. There are three big hospitals in one trust, so Basildon Hospital, Broomfield Hospital, and Chelmsford Hospital. And between us, we have just under 200 children, so from 0 to 18, with hemoglobinopathy, so sickle cell anemia and the related conditions. And myself and another lady, Dr. Eva Thorano, run the service. We've got a very big MDT with sickle cell specialist nurses. We feed into the Barts and the London Hospital as our tertiary hematology centre. So that's just a bit of background. And I think we've already said, if there are any questions, put them in the chat box, and if you just read them out to me. And I'm happy to pause as we go along. So talking about acute management of sickle cell painful crisis in pediatric ED. Oops, okay, first thing is the thing's not shared. So, okay, it's moving. Panic over. So the learning outcomes will be learning to recognize a painful crisis in a child with sickle cell anemia, and to initiate effective management of the pain, to become more comfortable with the use of opiates in pediatric sickle cell anemia, which, as you may know, opiates are the mainstay of treatment. Right, I don't know. Okay, so just a big summary on reminder on sickle cell disorders. So as we know, they're a heterogeneous group of disorders in patients who have hemoglobin S as their major hemoglobin, as opposed to hemoglobin A, as you're aware of. So we've got people with hemoglobin SS, SC, and S beta thalassemia, and those are the groups that we have, and the numbers are in that order. So more of them have SS, the next group is SC, and then we have a few sickle beta thalassemias. But I always say to my junior doctors and students that any of them can behave anyway. So that sometimes people come with a conception that if you're hemoglobin SS, you'll be worse off, and if you're SC or S beta thal, you'll be better. You fare better. That sometimes is true for groups, but individuals in each group can quite often surprise us. Quick slide that you've probably all seen, just showing you normal red blood cells, and then nice donut shape, and then showing you your sickle cells, which historically was named after sickle. That was an instrument used by slaves to harvest rice back in the day. A lot of children now, when I see them in clinic, and I'm talking about sickle cell, I describe it as a banana-shaped cell if your bananas come curved, because most young people have never really seen a sickle before, but we can talk about that on another occasion. So clinical consequences of sickle cell disease, as you know, you have, because of the abnormal hemoglobin, you have anemia. They have an increased susceptibility to infections, particularly the encapsulated bacteria, which is why they all go under penicillin prophylaxis. And then they can get frequent vaso-occlusive crises, which, quite putting it really simply, is when these sickle red cells get stuck in the vessels from head to toe. Then they can also have acute and chronic tissue damage. So things like strokes, avascular necrosis of the hip, and retinopathies. And unfortunately, there is reduced life expectancy, which life expectancy is getting better every day, but there is reduced life expectancy from sickle cell anemia. So this is a picture, again, that I present most times I'm talking about sickle cell anemia. And it's just to remind us that this is a multi-system illness, a multi-system disease, a multi-system disorder. There's no organ in the body that is not affected by sickle cell anemia. And when I talk to my little patients, I say, you know, everywhere that your blood has to go through, so from head to toe, will be affected by these sickle cells. And that's just a reminder, so that every time you see a patient with sickle cell anemia in front of you, it could be any organ. And quite often it's a combination of organs. One of them might be the focus of the encounter, but most of the organs will be affected to varying degrees at different times. So crises, I like to think about crises. I'm just saying, I can't see the chat box. Let me, hope it doesn't distract me. I won't look at it. So I like, this is the word crisis, and we talk about sickle cell crises a lot. And I just like if people can quickly put in the chat box what they understand by crisis as an English word. So not particularly pertaining to sickle cell anemia, but just when you hear crises, what does that make you think about? Just for 1 minute.
I've got my eye on the chat, I'll let you know.
Okay, and you can just shout out what they, so what are the, I think, I think somebody's not on mute. We all be on mute. So when you hear the word or you see the word crisis, what do you think about? Everybody's quiet.
Hi, sorry. Carol, if you're on mute, if you can mute yourself, if we can hear background. There we go. I haven't seen any comments.
Okay,
in
I'm
chat.
sorry.
No worries.
Okay.
We've got one comment says a flare.
Yeah, a flare. Okay, fantastic. Thank you. So when you, any others? So there are about 18 people on the listening. Any others?
One so far. I'll let you want to start coming through.
So if anybody, when you hear crisis anywhere, what does that make you think about? Okay, I think are we a bit shy, I think?
I think, yeah.
Yeah. Okay, so I'll move on, but I find it really interesting, and I like to, you know, when you have talks where you're in a room together, I kind of make people unwell, misery, yes, something painful, yes.
Yes, there we go.
Yeah, fantastic, thank you. So just going to, okay, some more, disaster, yes. Disaster, can you
big event.
Big event, yes. I can't, yeah. Anything else there?
Not yet.
Cool, so keep them coming. So
sudden bad event.
A bad event, yeah, fantastic. So crisis in English language, I actually looked it up in the dictionary when I was going to do one of my numerous talks, and these are the words that you can use instead of the word crisis. So catastrophe, calamity, emergency, disaster, trouble, hardship, distress, difficulty. And I think it's really important when you think about a sickle cell crisis, I think it's really useful to think about these words. So a patient who has sickle cell has come in an emergency. Maybe as clinicians, we get too familiar with the word emergency, but has come in trouble, has come in distress, has come in difficulty. And actually, very many of these encounters to the emergency room can be catastrophic, as I'm sure some of you will be aware, to all kinds of levels, from morbidity to even causing mortality. So if there's one thing I'd like you to take away from this, it's when that patient with sickle cell anemia presents in front of you and you say sickle cell crises, think a bit more about what that word actually means, especially for that patient. So crises recognition. So we know the deoxygenated sickle hemoglobin will cause a decrease in the red cell. So the red cells, if you remember the first few slides I showed you, you have the beautiful donut shaped cells. They're easily deformable. So you can imagine they can go through your big aorta and they can go through the tiny vessels in your periosteum and in your bones and in your brain, and they're fine. They just change to fit the vessel that they find themselves in. Now, these sickle cells, when they're deoxygenated, they lose that deformability. So they then become rigid, they become distorted, they take on that sickle crescent shape, and they're dysfunctional. And so that's what predisposes them to getting sticky and getting stuck in the vessels. They have a shorter lifespan. So your normal red cell will last for about 90 to 120 days. Your sickle red cells last about 10 to 20 days each as their lifespan. So they're constantly being broken down and the bone marrow is constantly trying to catch up. Like I said, the sickle cells don't flow as easily, so they get stuck in the vessels. So you get your vaso-occlusion and then subsequent hemolysis. And so there's always a bit of inflammation going on, which is why when you do bloods in these patients, your white cells are almost always a bit raised, your neutrophils, because there's almost like an ongoing, really acute on chronic inflammation that's always there, even when they're well. So these vessels then go and slow down the blood flow, or they can even totally obstruct the blood flow. So that's where you actually see swelling. There will be oxygen deprivation beyond the obstruction. And again, when I'm teaching medical students, I say, if you think about your plumbing at home and you have a pipe in your kitchen, and if something blocks one end and the water's coming from the normal end, it gets to that middle, that blockade. And so everything beyond it, there's lack of water, lack of oxygen, whereas the water keeps coming. So eventually something's got to give. And because these are vessels, tissues, they just keep stretching and they become painful. And you have the swelling that you can sometimes see in larger limbs, so in the limbs, for instance. Okay. Again, this is just another picture showing you your beautiful normal donut shaped red cells flowing through your vessels. This is a cross section of the red blood cells. And then the picture at the bottom of the page shows you your sickle cells and how they've now lost their beautiful donut shape, and they just go and clump and get stuck in these vessels. So triggers. I don't know if people are still feeling shy, but does anybody want to put in the box the triggers for a sickle cell crisis that you're aware of?
I'll read it again.
Yeah, thank you. Triggers.
I can start.
Yes.
Hello,
yes,
yes, please do.
shout out. Yes.
Yeah. I would say fever, infection, stress, high attitude.
Yeah.
Yeah.
Fantastic. Yeah.
This probably some, of course,
Yeah.
the most common is unknown, but this probably some of the risk, factors that can contribute to vaso-occlusive crisis.
Yes, exactly. So
we also
fever.
got dehydration, altitude, and pregnancy in the chat, as well as cold, hypoxia, sepsis, and dehydration again.
Fantastic. Thank you very much. So people are warming up. Thank you. And like you said, the first person who spoke, sometimes you don't even know. So, and it's really sad when I tell my teenage patients that actually, sometimes you can look after yourself. You know, the parents are always like, oh, it's cold, make sure you wear warm clothing, or it's hot, make sure you drink enough. But sometimes even when they're doing all those things, they can still just have a crisis for no real known reason. And that is one of the things that we have to deal with and we prepare the young people for. So yes, everything you've said is on there. Excessive temperatures, so when it's too hot. So when we have summer, which is not a lot of the year, we can get more crises, or sometimes so as you know, a lot of these families are from have an African background, and sometimes they can go away on holiday. So the ones I look after, and you find that when they go away on holiday to West Africa and the weather's really hot, So we say to them, make sure you're drinking and make sure you look after yourself. But then back here in England, when one common thing I see is they go for swimming lessons, and the parents will say, we're not swimming anymore. And I say, why? And they say every time they go for swimming lessons, they have a crisis. It's because they come out from the warm pool into the cold environment and they don't regulate their temperature. Well, they don't look, sometimes they spend too long in the cold, so they get a crisis. So we educate them on how to look after themselves. Infection. So again, every cough, cold, diarrhea, gastroenteritis, whatever infection that any normal child will have, a child with sickle cell will have the same infection and may have a crisis. And quite often the families will say, oh, everybody in the house has diarrhea. Yes, and they were fine, or they managed it at home, but the child with sickle cell will probably end up with a crisis, or is at risk of ending up with a crisis. So there is a lot of my job, I try to educate families so they know to look out for these things. Stress, so when they're doing their GCSEs, when they're doing their exams, when they're emotionally unhappy, you know, they've had a fight with their parents, they can come in with a crisis. Overexertion, so one I used to have a lot of a few years ago was at school, they do a cross-country race, and quite a few of our children will do the cross-country and then they'll end up in hospital by evening with aches and pains. You've talked about dehydration. I've just put on their nutrition, although most of our families are really, really good and they're very careful about their nutrition. But then when they go into the teenage university age, alcohol, smoking, drugs, so we do try to educate them. And then a big one is when you say hypoxia, so iatrogenic hypoxia. So when they're going for surgery, a big consideration is that if a patient with sickle cell anemia is going for surgery, they have to be anesthetized by an anesthetist who is expert in people with sickle cell anemia, because the anesthetic on its own, that hypoxia can put them at risk for a crisis. If there are any questions, let me know. So quickly, these are just some cases from our own A&E that we've had in the last few years I put together. So a 5-year-old boy was seen in A&E. So they all have sickle cell anemia. They all have sickle cell anemia. So 5-year-old boy seen in A&E, pain in the legs and arms. Another is a 13-month-old boy. He had a temperature following his MMR jab and he just wasn't settling. So they brought him in. A 7-year-old boy had a fever, came in with his head was hurting. Another 7-year-old boy had a cough for 5 days, and when he arrived, his oxygen saturation was 82% in air. Another 7-year-old girl, mom just said she had a headache, she had a fever, and she was off her feet, so she just stopped walking. And then an 11-year-old boy carried in by dad. So I remember this one, dad actually carried him on his back and brought him into our A&E, and he had pain to his back and sternum. So you can see the big feature is the vaso-occlusive crises and the pain. And that's just a flavor of how they can present. So types of crises, vaso-occlusive crisis, which is what we're going to focus on, and then everything else there that we've kind of touched on. So infection, they can have splenic hepatic sequestration, your aplastic crisis, hemolytic crisis, and all of them down to priapism. So vaso-occlusive. So this is the commonest kind of crisis that you get in sickle cell anemia. And like we've already said, it occurs when the microcirculation is obstructed by the sickle red cells. And so it then causes injury to the organ that is supplied and pain. And if it's an organ where you can see it, so such as a long bone, you can get swelling, you know, in the thighs or the limbs. Recurrent episodes of this acute severe pain will lead to tissue ischemia, due to tissue ischemia. The pain can be unpredictable, and like we said, it can occur spontaneously, so for no clear reason, with or without a trigger. It is responsible for 90% of admissions with sickle cell anemia. So 90% of the people you will see in your ED with sickle cell anemia will come in with vaso-occlusive painful crisis. You might see 2 to 3 sites each time, and the sites of pain can vary. So every time you go back to review, the pain might have, they tell you the pain moves. And that is seen a lot, so it's important that you keep re-examining them. And it can affect any tissue or organ, but most commonly is a deep muscle, the periosteum and the bone marrow. And if you remember that picture I showed you, the head to toe picture, basically any organ can be involved. So it's important to be aware of, you know, if they're saying headaches, you need to be thinking what's going on there. And if it's their limb, those are generally easier. So yeah, they have frequent hospital admissions, and these admissions have been shown to be associated with increased mortality. Inadequate treatment can lead to higher incidence of chronic pain. So I do pediatrics, but I know that in the adult world, you do have a lot of patients with sickle cell anemia who are now in chronic pain clinics. One thing I always say to my team is respect the pain. If they tell you that they're in pain, they're in pain. There's none of this business of saying, oh, they're playing on their phone or they're smiling. If the person with sickle cell anemia says, I'm in pain, the minimum that we can do as clinicians is to respect that pain and treat it appropriately. A lot of them are just used to being in pain. They're used to lying still. The teenagers will be on their phone, but they're just distracting themselves. It's not because there's no pain. Sometimes I get people saying, oh, Dr. Kilali, she's fine. She's been on her phone in bed all day. And I'm like, yeah, that doesn't really rule out pain. You need to speak to them. And if they say they're in pain, respect that pain and treat it appropriately. This is a picture just showing dactylitis in an infant, which I thought I would just put up there. And in the toddlers, this is what you're more likely to see. So signs and symptoms, we've been saying it all day: pain, swelling, fever. So management. Now, it was a bit tricky because yeah, I tried to make it really neat. However, one thing I will say is for every department, I don't know if you're from different hospitals, but every department should really aspire to have their own sickle cell pain protocol, so that in that department you get used to your own protocol. It should be agreed by your anaesthetist, your pharmacist, your hematologist, and anybody who is looking after these children or the adult patients. And so everybody just is familiar with it, and so that everybody's saying the same thing. And when you say, oh, this is what we're going to do, people don't then say, oh, where did you get that from? Or what are you talking about? So I think it's important. One thing I wanted to say was every department, if you haven't got a sickle cell pain protocol in your department, that's something to go away and start to think about. What is your department's protocol? What do you all do when these patients come in? What I did for this presentation is I went and looked at actually our NICE guidelines. So NICE is the National Institute for Clinical Excellence, which provides guidelines for every condition that we look after in the UK. And they have a good section on that, and you can just Google it if you wanted to use it as a starting point. And basically it says treats, and this is a sickle cell crisis. So it says treat it as an acute medical emergency, follow locally agreed protocols, which is what I've said. So every department should really have an agreed protocol. Regard the patient and or their carer as the expert. This is what I was saying about respect the pain. Listen to their views and discuss with them. If they tell you the last time I came, I needed 10 milligrams of morphine, there's no need starting on 2 milligrams. Start on the dose that they tell you works for them and worry about other things later. Discuss your plan with them, discuss their previous episodes. How did they come in? What made the difference? What helps them? Discuss any concerns that they might have. And also it's important to think about their psychological and social support, again, depending on your setup. Assess the pain. Again, these are NICE guidelines. Use an age-appropriate tool, and I'll show you what we use in our own department. We have a tool that we've designed that we use in our own department, and we've spread it out across our 3 hospitals so that we all use the same thing, so that all the nurses and all the doctors are used to it. The NICE guidelines say that analgesia should be offered within 30 minutes of presentation. That is an audit point. We constantly re-audit ourselves, and it's something that we're really proud of, that from when they walk in with their pain, they should have analgesia within 30 minutes. They shouldn't be in a corner crying and waiting to see someone. Assess all the patients clinically, blood pressure, oxygen saturations, which we would do anyway. If the saturations are 95 or less in air, offer oxygen therapy. You want to be looking at their heart rate, their respiratory rate, and their temperature. Again, yes, it might look like straightforward sickle cell vaso-occlusive painful crisis, but always consider alternative diagnosis, especially if the patient tells you this is not my usual pattern of pain. So analgesia, we've already said, sorry, this slide is a bit busy. We've already said take into account what they've had before. If it's a patient that you know and you have their details, some patients might have their own personalized plans. Make sure that the drug, the dose and the route are suitable. So if they're coming in vomiting, then there's no point in giving them Oromorph because they're being sick anyway. Consider the patient. Some of our patients can't swallow tablets. So, you know, we have to give them suspensions. And if they have an individual care plan, stick with it. Use bolus of strong opioid by the suitable routes in accordance with your local guidelines. We'll go into that. All patients should have regular paracetamol and NSAIDs. We use paracetamol and ibuprofen in our pediatric group, and that goes on the drug chart regularly. One thing is that most of the families would have been doing, by the time they come to hospital, they would have been giving paracetamol and ibuprofen regularly at home. Most of our families will do that. So when they come in, you need to step it up. The NICE guideline, interestingly, says do not offer pethidine. We don't use it, and it's interesting to know what your practice is, and that's because of the respiratory depressant effect that it can have. Reassessment, so you have to continually assess the effectiveness. So you give your pain relief, you need to go back in 30 minutes. Has it made a difference? If not, what else are you doing? What else can you do? Did it work? If that dose didn't work, can you increase the dose? Are you on optimal doses? Speak to the patient. Do they feel that they need more pain relief? Do they feel that they're coping okay? And if you've run out of your routes for administration of your opiates and it's all not working, then you might want to consider a patient-controlled analgesia, so a PCA, which again is why you should have a protocol that is agreed with the anaesthetist, so that when you call, for us, we have to call the anaesthetist, and it's important that they already know that protocol, they've signed up to it, so that we don't then start to have heated conversations about what should and shouldn't happen when the patient's crying in the corner. So opiate supportive care. Once you start the patient on opiates, you should prescribe laxatives on a regular basis. So we use Movicol, antiemetics, so we use ondansetron, antipruritics, so we would prescribe some chlorpheniramine or cetirizine, and you have to monitor them because of the opiates for adverse effects, using any standardized sedation score. I'll go through that in more detail. Then always to remember the non-pharmacological interventions. So coping mechanisms, their own relaxation techniques. Some of them will use heat pads. In addition to everything else you're doing for our children, we provide them with computer games, virtual reality kits. We have TVs and DVDs that our play specialists will bring around just to make them comfortable and to try and distract them. Hydration, very important. So we prefer, generally with sickle cell management, we prefer oral hydration. So and they're very good at drinking, because in clinic we always say you have to stay hydrated. But if they're not able to drink their maintenance, then we will consider putting up intravenous fluids for them. If they don't respond to standard treatments, keep reassessing. Is there something else going on? Are we missing something? And then as soon as that event resolves, it's important, the aftercare is also important. So follow your locally agreed protocols for managing the step down and how you're going to do that. It usually involves weaning of opiates. What opiates can they go home with? Who's going to follow that up and who's going to take care of that? I hope we're all doing okay so far. This is just a picture. This picture was of a little boy having intranasal diamorphine from his nurse, and that's just there. Just some of the things that we do. So this is now our own. So this is the sickle cell pain pathway pain protocol that we use in my hospital. It was adapted from this protocol used in the Barts and the London Hospital. We've kind of modified it to suit ourselves, and we have two arms. So this is what is in front of you is the arm for the less than 14 years. And then there's another arm for over 14 years. So every child that comes to our ED who is less than 14 years, in our ED, we have an alert system. So once they book in with their names and say, my name is Kilali, the system will say, alert, this child has sickle cell anemia. So people know to take them straight into a bed and alert the nurses that know that a patient with sickle cell anemia has arrived and protocol needs to be followed as per pain relief. So as they come in is time 0 hours on the left. We give intranasal diamorphine, and that's the dose. And that intranasal diamorphine is given together with Oromorph. And that's the dose we use. And the reason that they're given together, people often will say, oh, do you want one and then the other? And the answer is no. You want them together because the intranasal diamorphine acts quicker, but will also wear off quicker. And it will give the Oromorph time to then kick in. So you give both, try and get on top of that pain. You prescribe their regular paracetamol and ibuprofen. Again, you can use BNF doses. You do their mandatory OBS, and then in an hour, they can have more Oromorph. So an hour from the first one, they can have another dose, same dose, and then by 3 hours, so then they've now been in the department for 3 hours, they can have a third dose. So 1 hour between the first two Oromorphs, 2 hours between the second and third dose, and then after that, we give 4 hourly Oromorph for our children at this dose. Now, if the pain is not improving, on the 4 hourly Oromorph, or they're still screaming in front of you, we start our modified release, so long-acting modified release, MST, which goes, is 1 milligram per kilo, 12 hourly, and you can take that up to 70 grams in the under 14s. So there will be on the MST, then more Oromorph, paracetamol, ibuprofen. If pain is improving, you may not start the long acting. You might just keep going with your 4 hourly Oromorph and see how you get on. And obviously, like I said on the previous slides, if the pain is not improving despite this, then for us, we would then think about a patient-controlled anesthesia and get our anaesthetist set this up. So we would be talking to them to come and review the child. And this is the protocol for the children over 14. The big difference is if you try to give intranasal diamorphine or fentanyl to these children, because it's per kilogram of body weight, the volumes are too much, so you lose a lot of it. So in the over 14s, we give them a fentanyl lozenge. The little ones quite often are not able to suck on it effectively. So in the older children, they get a fentanyl lozenge together with the Oromorph. And then the rest of the protocol is pretty much the same. So paracetamol, ibuprofen, in an hour's time, they can have the second Oromorph. By 3 hours time, they can have the third one, and then it's 4 hourly, and you start your long-acting MST, your long-acting morphine. And again, if they're in severe pain and things are not getting better, you consider a patient-controlled analgesia. I'm just going to pause for a minute. Any questions, any comments at this point? Because we're pretty much come to the end of it. I'm just going to now show you our integrated care pathway, which is what we just embedded this protocol into a document so that once our patients come, that document is where we do the clerking, the documentation, everything is in that one document. So people don't start looking for what is the protocol, what is that? Yeah. So any questions or comments before I bring up the next document?
If you have any questions, you can always unmic yourself or just put in the comments if you don't want to say it verbally.
Excuse me?
Yeah.
I am Wahid studying from pediatric hematology. You mentioned that whenever the patient came to emergency, you give him the first time intranasal morphine, huh?
If they're in severe pain.
Yeah. Is it common in practice to give intranasal morphine? And because we don't have available intranasal morphine in our hospital and we didn't use it at all. So is it common practice in center in UK to give intranasal morphine?
Yeah. So we use intranasal diamorphine. It's common practice. It's also used in our burns units, in all, where they also look after children with pain. Recently, we've had a shortage in diamorphine, so we are now using more of intranasal fentanyl, but it is common practice. But this is why it's important to have your departmental protocol, so you know what you have, what is available. Because I remember for us, we've used intranasal diamorphine for a very long time. When we were told there was a shortage, we had to have a lot of meetings to say, right, there's a shortage, what can we use now? And then working together, we were like, okay, we'll use intranasal fentanyl. Yes, that's a valid comment. Again, you need to go back to your various departments and see what is available on ground. But
we do have a protocol in our hospital, and it's based on IV morphine.
For children as well?
Yeah, children. Yeah.
Okay, so we've worked very hard. When I say we, Professor Telfer, Drs. Banu Kaya, the team at Royal London that I work closely with, they've worked very hard to develop protocols that are all enteral opiates for children.
Is it effective, this one, intranasal? And does it have a side effect of morphine, like respiratory depression? And
no, not really. Usually within half an hour, the effect is worn off. But they start to get the relief from it usually within 10 minutes. But so if you give the intranasal on its own, within 10 minutes, they'll feel comfortable. But by the time you come back within half an hour to an hour, the pain is back, which is why we give it at the same time with the Oromorph.
There is a side effect of intranasal, like respiratory depression?
No, we don't see that. Not at the doses we use. No, not at the doses that we use. No.
Can the patient use it at home?
No, we don't. So we don't give it for home use. Definitely, we don't give it for home use. And even more, opiates as a whole in our centers, we hardly ever give them for discharge. We hardly ever discharge children on opiates. We use them very generously in hospital, but we would almost never send them home with it. It would be only in very special circumstances.
Thank you.
Okay, great. That's a good, yeah. So again, it's about what is available. So I will now just unshare this one and just bring up our ICP, which is pretty much same thing, but it's just showing you the document that we use. Where have I put it? Okay, that's it. So, sorry, I'm having a moment. That's not rolling. Give me a second. I'll stop share. Where is it? It worked beautifully before we started. That's the one. We'll try again. Can you see that slide? Oh, yeah. Oops. Can you see that slide?
I can see your webpage, your Word document. Yeah, it's rolling now.
Yeah, okay, it's rolling. I think I've upset it a bit. It's okay. So this is just to show you the document that we designed, embedding that protocol that I just showed you. So when you come to, if a child comes to any of our 3 hospitals and they come in and they say sickle cell anemia, we have these, we can print them off immediately, or they're printed in a drawer somewhere. And all the clerking, all the documentation is done on this document. So we call it the Pediatric Sickle Cell Crisis Integrated Care Pathway. So at the top left, we put in a label or just their name and all of that, the doctor, the time they saw, the weight. So our nurses are very good. They will weigh the child so that you can start prescribing the analgesia really quickly. Oops, so I'll try and roll it slowly. So again, you can see this is just that protocol I showed you, telling you, so if they're less than 14 years, the intranasal diamorphine, the dose they can get. And here we've updated it to include intranasal fentanyl. Because we've had this shortage with diamorphine, we had to update it. So if there is diamorphine on the day, we use it. If not, we use intranasal fentanyl, and those are the doses. And at the same time, the Oromorph. If they're above 14 years, then they get the fentanyl lozenge, which is just a sweet that they suck on, and they get Oromorph, or they get the Sevrodol tablets. And then it's just a reminder, because we have doctors that are rotating who may not be familiar with our systems, and this just makes it easier for them to follow. Again, it's the same. So it says at 1 hour, the nurses will reassess what is the pain score, how is the pain, they can have more morphine. At 4 hours, they assess, 5 hours, they assess again. Sorry, I'm going too fast. Oops, this is not, yeah. So it's kind of, it just reminds everyone when they can have stuff. And then this at the bottom, if they're not improving, we start the MST and the doses, and then a reminder at the bottom. So once they're having their Oromorph, all the laxatives need to be prescribed. The antiemetics, naloxone would be prescribed in case of respiratory depression, and antihistamine, and we do spirometry, which we've put on there as well. The The other thing that I wanted to show you on here is the, okay. So also on this chart is our pediatric pain assessment scale. So we've got different scales. So the typical one in the older children is on a scale of 1 to 10. How bad is this pain? But for children who cannot, you know, the younger ones who cannot give you that assessment, you've got your pain assessment scales, which are really useful. So this is the FLAC tool. It's suggested to be used between 2 months and 7 years of age. You look at their face and then you make a score. So for the face, if there's no expression or they're smiling, that's 0. If they're frequent to constant quivering chin, clenched jaw, you score them a 2. So basically it's an observational assessment of pain. But again, it's just important so that we're all doing the same thing, because, you know, doctors, we change shifts and all of that. And so that if I'm at home and they're telling me about the patient and they say the FLAC score is 6 or 7, I know I can have an idea exactly what is going on. The other, so yeah, that's just instructions. I think this has been shared with you, so you can look at it in more detail. The other, so we've already talked about the numeric scale, which is the common one. On a scale of 1 to 10, what is your pain score? And this is suggested for children 7 years and above. But you find some children, even at 14, 15, are not very good at describing their pain. So you still resort to, so I always ask my team, so when they say, oh, he's the patient is comfortable in bed, so for instance, a 4-year-old came in with leg pain and they say, oh, he's comfortable, and I will say to my registrar, have you made them walk? Have you asked them to walk? Are they able to walk to the toilet? And if you ask the mothers, what do they normally do? And they say, oh, normally they're running around, but this child hasn't walked, but is lying quietly. So for me, that child is still in pain, even though they're not screaming their heads off. There's another page, just a bit of a box for the nurses to do their own. So even the nurses will do their own documentation on this document. Then the clerking is also on here. So again, we've had good feedback in the sense people who are not familiar with sickle cell anemia will, you know, you can just pick this document up and confidently see the patient. So are they sickle SS? Are they beta thalassemia? Are they SC? What medications are they on? And there's a reminder there to check compliance. Are they really taking their medicines? Are they on any other medications such as regular transfusions, hydroxycarbamide, iron chelation? And as you know, some patients and their families are very good at giving histories, others are not so good. So this just reminds you what to ask. Sorry, and then typical pediatric history, so any allergies, immunization, I can't get that page to, so the history of presenting complaints. So when did the pain start? Where is the pain? Is it moving? Is it getting worse? Is it staying the same? And then is there fever? Are they coughing? This is just, again, it's just the clerking, but it makes it easier for people who are not familiar with, because when I first started looking after children with sickle cell anemia, when they come in pain, a lot of people would run away and just be like, oh, the patient with sickle cells come in, I don't know what to do. And, you know, you find people avoiding them because it's not if you're not used to looking after them, it can be quite intimidating. So these tools have really made it helpful so that whoever sees them, you know, we're doing the same thing. Past medical history is on there as well. Previous significant crises. So have they been to intensive care before? What for? Do they have other conditions, you know, like asthma? And then the transcranial Doppler results. So it's also on there as well. And we've just said you can find this in the clinic letter because some of the families will not be sure. But it's a reminder for the doctors. The steady state HB, again, some families don't know what it is, but we put that box in there so that the doctors know where to look. Immunizations, pneumococcal booster. So everything is on there. And then the examination, the documentation. Then we talk about the blood tests to do. So for all our patients, even if they're really well, we'll tend to still do a full set of bloods. We'll do a group and cross match, even if at the time you see them, they don't look like they need a transfusion. What you find is 3-4 days into the admission, they made it a transfusion in the middle of the night, and you don't want to be having to do your transfusion cross match then. So we say whenever our patients come in our department, our protocol is always do a group and cross match if they come in unwell, so that the blood is available when you need, if and when you need it. Blood cultures, depending on the history, parvovirus serology, mycoplasma PCR, again, those are depending on the history. We talk about x-rays, so chest x-rays if there are respiratory signs, or if there's acute drop in the hemoglobin in the absence of respiratory signs. We put the bit about not doing limb x-rays there because, you know, in the past, when people are not familiar with sickle cell anemia, they come in with their limb pain and somebody does an x-ray, as you do with any other pain. So that's clearly there to say, actually, if they've got sickle cell anemia and there's no history of trauma, you do not need, it's a reminder to say you do not need an x-ray. We've got a box on fluids just to make them aware of the fluid hydration status. We don't hyperhydrate anymore. We rather tell them to drink their maintenance. If they can't drink maintenance, then we put up IV fluids. And then we've put the spirometry chart on there because quite often it gets forgotten until our team comes to do the hematology round. You might find the child's not had their spirometry. So we put it on there as well so that it's prescribed and it starts from the ED. Just some guidelines on transfusion. Escalation for us is with the hematology leads, which is myself or Dr. Suwana, and if there's none of us available, then they speak to the doctors at the hematologists at Royal London Hospital. Again, this just goes through indications for top-up, indications for exchange transfusion, and I think that's it. Okay, there's another page on antibiotics, which I'm sure you'll have your own protocols, but we use ceftriaxone for children over a month. Children under a month, we would use cefotaxime, and that's sequestration crisis, chest crisis, or sepsis. If they've fever, or if they're well, they just continue their prophylactic penicillin. I've said a lot, so I think there's a bit on okay, we should go through this. So we've recently updated this to, so if you know your children who come in pain but are not screaming and are not in severe pain, so we've kind of broken it into mild, moderate, and severe. So if they're moderate, you can start your Oromorph, paracetamol, ibuprofen. Once we give them Oromorph, we don't send them home anyway. We don't send them home from ED. So if they've had Oromorph, they tend to get admitted and observed in hospital. In the older children, we still use codeine, and I know that's controversial, but we still use it to send them home. Our trust doesn't send. We'd rather not send children home with morphine, but we're slowly moving away from that because there's an argument that the morphine is safer. And if it's mild, then your paracetamol and ibuprofen, and that's usually in the little ones who are new, you know, like the young children who the families are not so confident with sickle cell anemia. So they might come to you and they've not had any pain relief. Then of course you start with your paracetamol and ibuprofen. I think, yeah, that's it. And there's a page for documentation. And that slide I've shown you before is also in this document, so people have something to reference. And that's it. So I'm going to stop sharing this and go back to, what am I going back to? That's me, I'm done. Any questions, anything? Yeah, you have my references. Let me go back to my main, I think the references are, I think I sent you the references, but if you need, I have loads of references. I can get those out. I think I've sent you.
Whatever you sent me, I've sent it over to the team.
Yeah.
So
yeah, this is just the main bits of it. Yeah, and that's the last slide. Yeah. So any questions?
Awesome. Again, if you have any questions, please put them in the chat, or you can just unmute yourself and just ask your question, however you feel like it. I'll give it a few minutes and now then we'll move on if we don't get any questions from anyone.
Okay, I'm going to stop sharing this so that I can see your faces.
There's no one there.
No one there. Okay, that's fine. So I'm not missing anything.
It's just me.
That's all right. Any questions?
Excuse me?
Any comments at
Hello.
all?
Yes, hi. Thank you for your lecture. I have one question. And do you have any idea about the experience for oral morphine as the first line of treatment in adults?
So that's a good question. I haven't personally used it, but because I don't look after adults, but I do know that with young adults who we've transitioned on our oral pathways, they do very well on it as well. And there's a separate guideline, which I can share with, it's a Bart's guideline. It's I can share that with you later to share with the team, but we have a separate pathway for the adults and young, for me, the young adults. And generally what we find is if in their previous crisis, they do well on the oral opiates, then we would just keep going with that. But there are a few, and I know a lot of centers with the adults use subcuts or intravenous opiates. And if there are a few that will say they only do well on PCAs, then there's no point going on to the oral. So personally, no experience, but with our not much experience, but most of our centers are using oral, so Oromorph for adults as well. I
think because we are rarely using this oral morphine, adult or pediatric. So starting patient on oral morphine, I don't know if they will be satisfied or not. So,
no, it's very, at the doses we are using 400, for the pediatrics, we're using 400 mics per kilo. There's caps up to 25 milligrams. They do the trick. They do the trick. I can assure you that they do the trick, but obviously it's changing practice. So yes, there will be, it's always difficult to change practice, but it's very effective. Yeah.
Maybe, as you said, in the transition, we have to start using it and we'll see the results. Thank you.
See the result, yeah.
Yeah, I have a couple of questions, and I will start from where you end. About codeine phosphate, we actually omitted from our guideline. We don't think it's safe to give codeine for painful crisis. I will need your comment about this. And second question regarding comparing continuous morphine infusion to morphine boluses in controlling painful crisis.
Yeah.
And my last question regarding transfusion, when you are using transfusion as a way of controlling pain.
Okay, so thank you. So continuous as opposed to boluses, and then transfusion. So I'll start with transfusion because that's the easiest one for me. If a child comes in severe pain and they need admission and their hemoglobin is 1 or 2 grams below their resting, so if this is a child that usually runs at 80 or let's say 90, they're in severe pain and they come in at 70, we would top them up because we know that it does have some effects on managing the pain. So so the answer to the transfusion bit is if they have dropped their HB below their resting steady state, we are keen to top up. As long as the HB is less than 10, we would top them up. We're very clean on topping them up. That's that one. I hope that answers that. In terms of continuous versus boluses, again, because of the side effects and morphine profile, and because in our department, these are pediatric nurses, I'm a pediatrician by background, not an anesthetist. We would rather use, so we use our oral opiates. Once we are not winning with the oral opiates, they go on to continuous infusion. So with patient-controlled analgesia or nurse-controlled analgesia, and that usually will have a background of, it will have a background infusion, then the boluses that they can administer themselves at time points. I think your question is which is better, or what's my experience?
Which is better and safer? There is some data about that.
Yeah, I don't have the data on. Yeah, I don't have the data.
Increase the risk for acute chest syndrome compared to continuous infusion, and you can use a smaller dose overall if you use continuous infusion compared to boluses.
Yeah, I agree.
So you thought about that, yeah.
Yeah, and that's and again, that's because when you look at the way, so for us, because we use enteral, so oral, we would put that, if they're staying in hospital, we would put them on the MSC, the long acting, so that provides the background, which would be synonymous with your continuous infusion plus so our PCAs have a background. I think that's what you're talking about. Plus, they're able to give extra boluses as required. But I agree with that comment. Yes, you rather give a continuous than boluses, intermittent boluses.
Okay. What about safety of codeine phosphate?
Yes. So codeine phosphate, I really try and stay away from the argument. It's an anesthetist discussion. Now, when I say our own, so our hemoglobinopathy coordinating centre, which is the service that looks after my hospital, which is Barts under London, they have over 400 children with sickle cell anemia, and they have a very good safety profile with codeine phosphate, and we actually use it as a step down to discharge children home. So we have a lot of children in the community whose parents will call my nurse and say, he's going to school, but he's got aches and pains. I've given paracetamol, I've given ibuprofen. Those children, we give them codeine phosphate at home. And our safety profile, and I know what the papers say, but we have a very good safety profile. So we continue to use that. We have members of our own team who will never touch codeine, but we use it at the doses that I've put on there. For the children under 12, we use dihydrocodeine. That's how we escape that. We use dihydrocodeine. That's how we escape the MHRA alerts. And again, we have a good safety profile with that. But like I said, one of our trusts, the anaesthetists will not touch codeine at all. So they would rather use Oromorph. But we are reluctant to send children home with morphine. We're reluctant. But when we have families that we know very well, we have a safety profile with the families when you know that the parents know what they're confident. Sometimes we will send them home with morphine, but codeine we would give everyone, codeine, dihydrocodeine as needed. So basically, typically what happens in our unit is they have their Oromorph MST, we slowly wean it, and then on the ward, we will switch them to some codeine or dihydrocodeine, and then they'll go home with a bit of that. Okay.
What about the new drugs?
Sorry?
Are you start using the new drugs like the new disease modulating therapy?
So I thought about a slide on that, but it was a bit outside ED management. So I think the main one, the newest one is canakinumab, which I took a while to learn to pronounce. So at the moment, it's only licensed for adults. So in pediatrics, we're not yet, as well, over 16s, adults. So we're not yet in pediatrics, we're not yet using it. But in the bigger centers, they've started. So in Homerton Hospital, for instance, I know they've started yesterday. Their first patient had their infusion. So we don't have our own as a hemoglobinopathy service. We don't have our own data yet, and we're all watching keenly to see how it goes. But we haven't started it in pediatrics. Our families have started asking us about it because it was in the news everywhere to say there's a new drug. We're going to wait patiently or impatiently to see how the adults get on, and then that will be the next step for us. We probably will use it in our teenagers first. Other things like dihydroxy, what we're using a lot of is hydroxycarbamide, which you're aware of, and transfusion. So most of our pediatric patients are on hydroxycarbamide, hydroxyurea and transfusions. That's what we're doing.
Yeah, okay, thank you.
You're welcome. Thank you for your comments. Yeah. Anything else, anyone else?
I don't see any messages in the chat. I don't see any other hands up. Give it a couple, give a couple more seconds. And if I don't get a response, I guess that, got a comment saying my experience with morphine infusion in kids is satisfying.
Yeah. The problem we have is, yes, I thank you for that. One of the problems we have in the UK is, I don't really have experience of healthcare where you guys are, but something happens, there's a lot of noise about it, and then things just stop. So what I'm talking about is, we used to have, when I was a junior doctor, we used to have nurse-controlled analgesia. So the analgesia will be put up on a HDU on a ward, and the nurses will be pressing the boluses. For so many reasons, we no longer have that except on ITU. So if you then put a 5-year-old on a PCA, they're in pain, but they don't press it. And the parents are not allowed to press it because it's a patient-controlled thing. So then we found, actually, you've got a PCA set up nicely, but it's not being used. The nurses can't press it. The parents are not allowed to press it. So these are the reasons why we moved away from PCAs and we stick with the enteral. But in our older children, the teenagers, they're a lot more able to use the PCAs, and they will use it effectively. Yeah. But we always have a background. So there's that background going, so that even if they don't press it, something is going. But yes, I agree. It's very satisfying, especially when you've got a child who's been in severe pain and nothing's working.
Okay. If there's any more comments, please say so now. There's no one else.
So are you guys? Are any of you pediatricians? Do you see children and adults, or adults alone, or a mix? Any comment? Yeah, from the team, the group. Do you see children? Do you see adults?
Well, some of us pediatricians, some of us is adult.
Adults, okay. Okay.
So it's a peds till 14.
Okay. Cool. Yeah. So in our center now, we look after children up. We can push it to 18. Once they hit their 18th birthday, they have to go. Basically, they can't be on a pediatric ward anymore, so they have to be in the adult service. But we like to hold on to them as long as we can.
I think that most of our doctor hematologist pediatrician in Kingdom of Saudi Arabia, they use the IV morphine as inpatient, you know.
Yeah.
I don't believe that maybe little of them they use the IV infusion morphine, but most of us, and I am one of them, and we have a protocol even by the Minister of Health that we use morphine sulfate every 4 hours, in addition to the morphine together.
Okay.
And in a matter of 2
Sorry, so it's a bolus. Sorry to interrupt you. IV morphine boluses.
Yeah, over 10 minutes. Yeah.
Yes. Okay. Okay. Yeah. Yeah.
Yeah, and we give it every 4 hours to the patient, plus PRN half of the dose every 2 hours if there is a pain. And we do that. We do fine with this.
That will do. That will do the trick. Yeah.
We don't encourage to use the pethidine and oral morphine because of the addiction, you know, and sometimes the side effect of the pethidine and oral morphine might cause some sort of seizure for the kids. So we need to use a lot of pethidine. And
we don't use pethidine at all. We haven't had any. We haven't had any side effects, especially not seizures with Oromorph. And I'm not sure what the data is with addiction, but my understanding is a lot of people feel the IV morphine predisposes them more to addiction. I mean, a lot of conversations about that. I think most hematologists would tell you that is not the case. If they need pain, if they're in pain, they need their morphine, and if it's IV that works, that's fine. But I think there's this idea in the community somewhere that if you know, people, especially in America, people, when adults with sickle cell anemia go to A&E, and people sometimes mislabel them as opiate seekers, which is wrong. But I agree, most of these patients will not come to hospital if they're not in pain. They don't want to be there. They only come if they're in pain. Yeah. Okay. Any interesting conversation? Really, really good. I've enjoyed it. So thank you.
That's good. Yeah. That's good. Since I can't see no more comments and no one's got their hands up, I would like to conclude today's presentation. Thank you so much, Doctor, for doing this presentation. I think it was very insightful. And I think we've learned a lot. Thank you all for attending the lectures as well. You've got a lot of thank yous in the comments for you.
Oh, yeah, great.
Again, if you have any questions, later on, put them in Slido and I'll send them over to Dr. and she will, I'll spin my response back into the Slido. But that'll be it today. So the lecture tomorrow as well. But as for me, I'll say have a good evening to all you all and a good afternoon to you, Doctor. And that's it. Thank you so much.
Thank you very much. Thank you for having me. Thank you.
Thank you. Thank you all. Thank you. Thank you.
Yeah, sorry for being difficult. I hope I'm sure your other presenters are not as difficult as me.
Oh no, there's one.
Thank you.
You were the one, the easiest one. It's all good.
Oh really? Okay. Yeah, I need a personal assistant to keep track of what.
Oh no, I think it's just doctors in general. You're also busy. Yeah. So I know it's hard to like reply to emails and stuff like that. So
yeah, clinical work always
thank you.
Priority, and then everything else kind of But I'm glad I've done this because I know last year I said I would do it and then I didn't do it. So I'm glad.
Fine.
Yeah. How is Baba?
I'm on annual leave this week, so I haven't seen him this week, but seems okay from last week.
Okay, when you see
seems
him,
happy and eager to travel again.
Extend him my regards when you see him. Yeah, thank you.
I will. Thank you so much again.
All right, you take care.
Thank you all.
Bye.
Bye-bye.